what I'm going to be talking about is myths and facts surrounding hormonal replacement therapy. So we are going straight diving into MHT as a therapy for menopause. So the first thing that I would like to make clear is that even though we know that half our adult life we are spending in menopause, we so many times are scared and worried about using MHT for certain reasons. I think the disuse happened because of the WHI study which was there, where they went into disrepute because we realized that there were a lot of problems which are happening. So one thing which is, I mean, the message that is there is that there's a particular time that the MHT should be used, which we'll be talking about later. And secondly, that, there are certain cases where it has to be used and certain cases where you don't use it. So probably that's what we are going to be discussing. But at the outset, I must say that there are 4 indications for using MHT today, which are supported by the International Menopause Society as well as the Indian Menopause Society, which are management of premature menopause or premature ovarian insufficiency, that is menopause before the age of 40, for vasomotor symptoms, for prevention of osteoporosis, and the 4th being for the genitourinary syndrome of menopause. So now moving, that the problem here today is that after the WHI, all of us got scared in using MHT in these cases also. And for that reason, a lot of women have not received the benefit of MHT. So is it that we cannot give it in certain cases? That is what I'm going to be talking about today in the form of case studies. So this is the first case. It's a 49-year-old lady. She's a para 2, having severe hot flashes, night sweats, and insomnia. She had her last menstruation 1 year, 4 months back, so clearly menopausal. And she presented at your clinic for relief of these symptoms. She has a BMI of 29, moderately hypertensive, and borderline diabetic. Her physician says that she should not take any hormones as she is at hypertensive on medication and diabetes controlled on lifestyle management. So what would be your advice to the patient? Again, one clarity that we should have, that all of us are scared to write MHT and we are more keen to use natural products. Not that I'm saying that they may not be of much benefit, but the problem is that we don't have scientific data to back it, while there is a very significant data available for backing MHT. So at least we should be knowing that what should be a line of management scientifically speaking. So this is a woman who is menopausal for almost a year and a half. She's having severe hot flashes, night sweats, and insomnia with a BMI of 29, moderately hypertensive, and borderline diabetic. So how should you approach? Lifestyle modifications are definitely important. The options that we have would be oral estrogen progesterone continuous combined therapy, oral estrogen progesterone sequential therapy, isoflavones, and tibolone. So what does the data say clearly? One thing here again I want to make clear, that sequential therapy we will be using only in women who are perimenopausal. Once a woman is menopausal, we look at continuous combined therapy because we are not looking at her getting her periods. So as far as women with type 2 diabetes are concerned, if she is more than 60 or more than 10 years of menopause or a high cardiovascular risk, we do not think of MHT in these cases at all. If she is obese or with moderate cardiovascular risk, we can use MHT, but we will prefer a natural progesterone or a neutral progesterone like dydrogesterone or micronized progesterone, which incidentally is the only progesterone that we are using today in MHT. In a peri or recently postmenopausal woman like this with low cardiovascular risk, we can comfortably give estrogen, the MHT. We will prefer oral estrogens and prefer neutral progestins. So the UK guidelines, the Endocrine Society, the Society of Gynecologists, they all say that MHT can be prescribed to women with diabetes for the relief of menopausal symptoms, and there is no adverse effect on blood glucose monitoring. And you must consider MHT for menopausal women if they have type 2 diabetes after taking comorbidities into account. So the myth is that MHT cannot be given to a diabetic patient, but actually MHT reduces insulin resistance and blood glucose levels. It also reduces the incidence of new onset diabetes mellitus. So it can comfortably be given. Does MHT cause weight gain? No. MHT is not associated with weight gain. It may in fact ameliorate perimenopausal accumulation of abdominal fat. And as ma'am said very clearly, that your calorie requirement in menopause should go down, your protein intake should go up, because the requirement of the body becomes less. So in fact, there is a perimenopausal accumulation of abdominal fat anyway. And probably a woman on MHT would be benefited because that would be ameliorated. So this is another case. This is quite a similar woman with the same history, hot flashes, night sweats. Having her menopause a year, 4 months back, she had her last menstruation. She has a BMI of 25. Now, her mother had breast cancer detected at 67 years of age at stage 2 and underwent complete treatment. The mother is now 76 years of age with no breast problem. This lady was operated for a fibroadenoma right breast at the age of 36. She still has another fibroadenoma, 3 centimeters in her left breast. She breastfed her baby well. So the first thing which comes in our mind is, oh, she has a family history of breast cancer. She cannot take MHT. So how do you counsel this woman and manage her? What should be our approach? Of course, lifestyle medication and oral estrogen progesterone continued combined. We will think, can we give her isoflavones? Can we give her tibolone? Can we give her SSNRIs or SSRIs, yoga and CBT or SERMs? So the concerns are, does MHT cause significant risk of CA breast? It's an extremely small risk according to the International Menopause Society guidelines of 2016, which is less than 0.1% per annum. The NICE guidelines say that HRT with estrogen alone is associated with little or no change in the risk. So estrogen alone does not initiate or promote breast cancer. Then what matters? Is it the estrogen or the progesterone? It's the progesterone which actually makes a woman more prone to breast cancer. The risk is primarily associated with synthetic progestrogens like MPA, and now the ones that we are using, that is dydrogesterone or micronized progesterone. The risk is extremely low and it is a very safe progesterone to be used if the woman does not have a family history of a young breast cancer. That is that her mother had breast cancer. In this case, if you see, at 67 years of age, she can safely be given MHT. So does MHT cause breast cancer? MHT is safe in postmenopausal women of less than 60 years of age for 5 years. Even a sedentary lifestyle, obesity, and alcohol consumption are associated with similar or greater risk than HRT. Risk of breast cancer is not the same with all MHTs, and the ones available today, that is with dydrogesterone or micronized progesterone, do not significantly increase the risk of breast cancer. And we are not going to be using a synthetic progestogen. Again, the same woman as the one we had earlier. Now, this is a woman whose elder sister died of DVT in her postpartum period. So she came to know from Google and is extremely apprehensive to take any hormone. So how do you investigate this case and counsel her chances of DVT? And can you prescribe HRT? And if not, then what do you prescribe? Because she is having hot flashes, night sweats, and insomnia. So what we know is that transdermal estrogens are less likely to produce VT, stroke, and CAD. They're definitely safer. So the first point is that, is VT risk high in women with MHT? VT is less frequent among Asian, non-obese, less than 60 years women. And women more than 60 years or more than 10 years post-menopause are at an absolute higher risk of CHD, VT, and stroke than women initiating HRT in early menopause. The risk is lower with transdermal MHT containing neutral progesterones like dydrogesterone or micronized progesterone here. So transdermal estrogen would be safe in such cases, but please do not make a bereft of the use of MHT. It can be given comfortably if there's a family history of DVT, but please see that that was in a postpartum period where anyway coagulation is known to be, a woman is more prone to DVT. So if it is triggered by something like an accident or postpartum period, we take that family history into account, that it is safe that we can give her MHT also, but use a transdermal estrogen. So MHT related risk for VT is rare in women till age 60. The incidence of VT is less frequent amongst Asian women, and oral estrogen therapy is contraindicated with women with personal history of VT. Now we come to a 65-year-old lady. I think all of us see these ladies in our OPD these days. Para 2 presented with recurrent UTI and insomnia. Her friend says that as you never had hot flashes, you don't need hormones. How would you assess the case and treat her? So this woman is obviously a case of genitourinary syndrome of menopause. So genitourinary atrophy is one of the inevitable changes amongst postmenopausal women, probably something little late to happen. So as a woman is in her perimenopause or postmenopause, probably the hot flashes is what would herald the menopause. But there are a lot of women in their 60s, 70s, and 80s where we say that it's not the golden period to start MHT, but that is when these women will present to us with genitourinary symptoms. These symptoms respond very well to estrogens. The vaginal route of administration correlates with better symptom relief by improving the vaginal dryness, pruritus, and dyspareunia. Long-term treatment is often required as these symptoms can recur on cessation of therapy. Systemic risks have not been identified with local low potency, low dose estrogens. So actually it is that even you can start MHT in these cases with local estrogen therapy, even without doing her pap smear, because her vagina is so dry that it is possible that you may not be able to do a pap smear also. So, and you don't need extra monitoring in these cases. Of course, the mammogram and the ultrasound, which we would recommend for every woman to be done at a particular time, has to be done. But no special investigations are required before starting local estrogen therapy. And we can even delay the pap smear or the examination for a month, telling her that it is very important to come back because we don't want to miss any other lesions. But we can definitely start therapy if the vaginal examination is not possible because of her vaginal dryness. So regular annual follow-up is required. So normally you can give them vaginal gels or creams in tapering doses, starting with a higher dose for about a month and then tapering it down. Combined MHT treating only VMS? Not at all. MHT remains the most effective therapy for vasomotor symptoms and urogenital atrophy. It improves other symptoms such as joint and muscle pains, mood swings, sleep disturbances, and sexual dysfunction and quality of life. It is also the most appropriate therapy for fracture prevention in early menopause. In women who are menopausal and having genitourinary symptoms, we need to give them only estrogen creams and no.
Kiran, kindly mute yourself.
Dr. Kiran, if you could just mute yourself, thank you. So the local estrogen therapy does not require any progesterone feed add back, even though her uterus is still intact. A 42-year-old lady, para 1, having regular menstrual history, started missing her periods for the last 1 year. Her FSH is 38 and she has been diagnosed as perimenopausal. She does not want to take medication but wants to know about chances of conception at this age. How do you proceed in this case? I think all of us would tell her to visit our IVF specialist friends or colleagues or investigate in that fashion. But considering that she's 42 and her FSH is 38, we would be looking from a menopause point of view at premature ovarian insufficiency. So the diagnosis is normally made if a woman is less than 40 years with oligo or amenorrhea for at least 4 months with elevated FSH levels of more than 40 international units per liter on 2 occasions more than 4 weeks apart. Another point I just want to make here when we are talking about this definition, that women who are over 40, because the natural age of menopause could be anytime between 40 to 55, with an Indian average about 46.2. To diagnose menopause, we don't need to do the FSH levels. Just her history is good enough that, when the cycles are irregular and if we see shrunken ovaries on the ultrasound, because the commonest reasons would be either uh, menopause or PCOS, in which there would be larger ovaries. So probably even a scan would be good enough. FSH is not indicated to diagnose menopause in women over 40. So women with premature ovarian failure have a 5% chance of spontaneous conception, and medical therapies have to be used, and probably assisted conception with donor oocytes have been used to achieve pregnancy in women with premature ovarian failure since 1987. It remains the only means of fertility treatment that carries high success rate, although there are a lot of new therapies which are being done, like stem cell rejuvenation and all of the ovaries. But currently, assisted conception with donor oocytes seems to be the way to go. This is a 49-year-old lady again, para zero. She's never had children, having severe hot flashes, night sweats, and insomnia. This lady had a hysterectomy 1 year, 4 months back. She presented at our clinic for relief of these symptoms. She has a BMI of 29, history of stage 4 endometriosis, for which the hysterectomy was done. Ultrasound pelvis shows a remnant of endometriotic cysts on both sides of the pelvis. So what will be her management in this case? Can we give her MHT or not? Which MHT regimen will be given, and should progesterone be given now? Because like I said, it's a very simple thing that anyone who is perimenopausal, if you want to give therapy, you will be giving sequential treatment. That is, for 14 days, we give her only estrogen. For 14 days, we add natural progesterone to it. And then after that, when she starts the estrogen pills again, she gets her period. So we use a normally a 1/10 in those cases. That means 1 milligram of estrogen, ethinyl estradiol, and 10 milligrams of dydrogesterone for the next 14 days added to the estrogen. When someone is having POI, we use a higher dose of estrogen. So we would use a 2 milligram dose of estrogen along with the progesterone, exactly in the same fashion, so that she gets regular periods. Once she's postmenopausal, then we don't want periods. So we would be giving her, say the pill would be 1/5, that is 1 milligram of estrogen and 5 milligrams of progesterone or dydrogesterone regularly. So it's just one colored pill which will go continuously, so that she doesn't get periods, but she gets the effect of the estrogen and back of progesterone, because her uterus is intact. If she is had a hysterectomy, then we don't need to give progesterone, because the purpose of progesterone is to prevent endometrial CA. Then we need to give her only estrogen, except in this case. If she has a history of endometriosis, we know that the endometriotic cysts will be there, which are estrogen linked. And in those cases, we have to definitely give an add back with progesterone. So progesterone has a place in management with residual endometriosis following radical surgery or subtotal hysterectomy. Dydrogesterone and micronized progesterones are both effective, or we can use tibolone. So in hysterectomized patients, we will give estrogen alone. Hysterectomized patients with endometriosis, we give oral combined continuous MHT or tibolone. But clinicians should continue to treat women with a history of endometriosis after surgical menopause with combined EP or tibolone, at least up to the age of natural menopause. Progesterone is added to prevent estrogen-induced endometrial CA. So this is what I was just talking about, that women who still have a uterus use estrogen and progesterone to protect the lining of the uterus. Women who've had a hysterectomy use unopposed estrogen or monotherapy. But women who have had endometrial ablation or surgery for endometriosis will need progesterone, because some endometrial tissue is present either inside or outside the uterus. Does MHT cause endometrial cancer? Unopposed estrogen therapy is associated with a duration and dose-related increase in risk of endometrial hyperplasia and cancer. Endometrial protection requires an adequate dose of duration of progesterone, which should be at least 12 days. So normally the pills that we are getting in the pack form, they have 14 days of progesterone in them. So this lady is similar, but here the only difference is that her mother and grandmother have already counseled her regarding menopause, that it's a natural event of life and no treatment is necessary. Her physician disagreed to put her again under any hormone, as she had a past history of jaundice and a family history of heart attack and hypertriglyceridemia. So how do you proceed? You have to give her relief. She has hot flashes, severe. She has severe night sweats, severe insomnia. She deserves to get MHT, because she is an ideal candidate and we need to help these women out. So this is a good chart to use, that we see her cardiovascular risk also. So if the low risk or acceptable for MHT would be someone who's had recent menopause in the last 10 years, normal weight, normal blood pressure, and an active female with a atherosclerotic cardiovascular risk of less than 5%. MHT at early onset of menopause or less than 5 years duration is comfortable. Low dose transdermal E2 patches are very comfortable. Vaginal creams, rings, and tablets, unfortunately, which are not available here, are comfortable to be used in women for as an MHT dose. Definite risk or caution with MHT: if she's a known diabetes, she's a smoker, uncontrolled hypertension, these issues need to be dealt with. Obesity, sedentary or limited mobility, SLE, rheumatoid arthritis, migraines with aura, high triglycerides, or a high atherosclerotic cardiovascular risk of 5 to 7.5, there is a definite risk, or you need to tread with caution. And there's a definite risk for giving oral combined MHT for more than 5 years or after age 65. High risk or avoid MHT: known atherosclerotic cardiovascular disease or pulmonary artery hypertension, known venous thrombosis, pulmonary embolism, known strokes, known breast cancer, or a high atherosclerotic cardiovascular risk. We anyway like to avoid oral combination MHT for more than 10 years or after 65. Unopposed estrogen in women with an intact uterus is to be avoided completely. Sorry. So we've dealt with this. Yeah. So in fact, like you see here, even the mean HDL increases with MHT compared with the 26.8% reduction of HDL with Tibolone. So MHT does better than Tibolone in early postmenopausal women. MHT is a good thing for menopausal women as far as their lipid profile is also concerned. So does MHT increase the risk of CHD? In women less than 60 years old who are recently menopausal and with no evidence of CVD, the initiation of estrogen alone therapy reduces CHD and all-cause mortality. There's no significant risk of women in less than 60 years, and early initiation of MHT actually reduces the risk of cardiovascular disease and mortality. I hope that the point of this presentation is not that we give it indiscriminately to every patient, but women who have symptoms, especially when we know that 60 to 70% of women have troublesome VMS or vasomotor symptoms when menopause starts. We should, if they are healthy, fit, young, we should not hesitate after, of course, a thorough screening in giving them MHT. I think that is the time when we start using it, we get the maximum confidence, and probably, once you start using MHT in your practice and helping menopausal women out with their issues, the confidence comes from there. And of course, continuous, training and learning is very important when we are using MHT here. Thank you so much.